It's fascinating. I mean, no question, this has really come at a point where the high selectivity that we tried with different drugs being either the anti-angiogenic that we saw at a long extent in the first-line setting, in addition to the different targets, clinical trials that happen in the second-line setting, and then you come with a multi-kinase with really not necessarily a fully understood mechanism of action, but obviously has this kind of, ability to target different kinases, with those positive results. No doubt it remains a fascinating component that I think we are in the field of HCC. We're going to probably spend quite a bit of time trying to analyze. With this said, one more challenge we're going to face, Katie, is that at the end of the day, regorafenib is already approved in colorectal, as we heard, and especially in colorectal, is kind of like really the kind of third line of therapy. And admittedly, it's not necessarily something that will come to mind, because until you get there, it's a really long kind of, projected time for a colorectal cancer patient. And now we're going to try to kind of, re-celebrate a drug that has not necessarily the kind of most glorified position, if you want to call it that way. So how can we do that? How can we explain that this is not really the same story?
Well, I think, it really depends on context and how healthy the patients are in their liver function and their visceral function, particularly in colorectal cancer patients at the time of starting the drug. I mentioned earlier, GIST patients often have very good tolerability of regorafenib, very similar to their tolerability of sorafenib in my experience. So I think, as Rich mentioned, the window of opportunity is to give patients a chance to try the drug when they're most fit to benefit and the most fit to have the least toxicity when liver function permits. So I think if we push sorafenib beyond progression until there's clinical decompensation or worsening liver function, it's logical to expect that the toxicity of a drug that's partially hepatically metabolized will be greater and the tolerability will be lower. And that's, I think, also our experience from colorectal, that fourth line setting, or when after patients have exhausted so many other therapeutic options, as regorafenib has experienced in the colorectal cancer population in many of our cases, there is more toxicity in that setting. And so I think the balance and the art of this will be learning when to transition from first-line therapy to regorafenib and identifying progression at a time when patients are able to capitalize on the second-line agent.
Fair. Laura, back to you. As you can see, our armamentarium is kind of like growing. We're at 2 drugs now. But nonetheless, still, interestingly, in the community setting, oncologists are not necessarily comfortable all the time with HCC, and especially because of the cirrhotic component, which is understandable, can be quite complex. So can you just kind of help us with some guidance that we can share with our colleagues in the community setting in regard to the management of the cirrhosis and who should be involved and why they should not necessarily worry all the time?
Well, it is important for hepatologists to be involved, one, to kind of leave some of those fears and work as a group. The multidisciplinary approach doesn't stop in our academic centers. I think it goes into the community as well. And these patients need, as I said earlier, they need to be screened for varices. This should be done. Patients with liver cancer are much more likely to die of variceal bleeding. Also trying to help them with ascites and encephalopathy is key. So I think pairing up with a hepatologist is going to be important for keeping patients on drug, because they may want to stop that because they develop encephalopathy for the first time. And it may be an inciting factor that you can say, okay, this is why this happened. We'll lower the diuretics. There's a lot of things that can lead to encephalopathy. So trying to figure out how to control those side effects as well as the symptoms of underlying cirrhosis, I think is also going to make the patient want to stay on the drug longer. I think this drug being second line now is very important for patients, because again, what I hear from patients is, I don't want to take this sorafenib because this is all you have left for me. And after that, there's nothing else. So patients are kind of waiting until they say, okay, I'm ready to go on it. Now, if you can tell them, okay, there's something else, I think there will be more from a psychological standpoint willingness to go on to systemic therapy as well.
Sure. That's very important as well. Is definitely we go back and you keep hearing us repeating the multidisciplinary approach. That's quite necessary in that regard. That brings us to a rather an important summary over here, at least about the current status of the therapies that really have shown improvement in outcome. As we just heard, sorafenib was an improvement in outcome with 10.7 months versus 7.9 for placebo, established the drug as a standard of care over a decade, as Dr. Finn mentioned, really with noble efforts trying to kind of, outseat it with different approaches, especially strong anti-angiogenics, and didn't happen. And now we have the advent of regorafenib, another multikinase, really very close, but with some different mechanistic actions and at least targets, which again bring up a improvement in survival for the extent of close or near to 11 months in the second line setting.